welcome to the ASCO Guidelines podcast, one of ASCO's podcasts delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Joshua Royce from Georgetown University, lead author on Therapy for Stage 4 Non-Small Cell Lung Cancer with Driver Alterations, ASCO Living Guideline version 2026.3.1. Thank you for being here today, Dr. Royce.
Thanks, Brittany. Happy to be here and to discuss the latest and greatest in the updates on driver mutation positive advanced non-small cell lung cancer.
Absolutely. And then just before we start that discussion, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Royce, who has joined us here today, are available online with the publication of the guideline in the Journal of Clinical Oncology, which is linked in the show notes. So then to dive into that exciting discussion, Dr. Royce, this living clinical practice guideline for systemic therapy for patients with stage 4 non-small cell lung cancer with driver alterations is updated on an ongoing basis. So what prompted this latest update and changes to the recommendations?
Yeah, Brittany. So obviously, to keep this guideline living and up to date, we continue to scour the literature to see what new peer-reviewed published data would inform any changes in our practice. So we really want to assess for that practice-changing level data so that we can keep clinicians and treating oncologists in the United States and around the world up to date so that they're providing the latest and most data-driven treatment decisions for their patients.
Absolutely. And speaking of that practice-changing data, what updated evidence did the panel review on first-line treatment options for patients with stage 4 non-small cell lung cancer and an EGFR exon 19 deletion or exon 21 L858R substitution, and how did this impact the recommendations?
I think you'll find today our discussion is going to be very EGFR-centric. And so I think to that point, it maybe warrants a brief overview of the EGFR mutated non-small cell lung cancer subset. So this is something activating EGFR mutations that, we've known about for quite some time now. They were the first driver mutation that really had an effective targeted therapy. It's an interesting story I won't delve too deeply into, but actually the therapy was around before we really knew who it was most appropriate for. But there's been several iterations of EGFR targeted therapies under development and evolution in just the treatment and now combination strategies in the front line specifically for EGFR classical alterations. So that's really the second key point, is that not all EGFR mutations are created equally. We have our classical EGFR activating alterations, which are the exon 19 deletion, the L858R mutation. That's probably seen most commonly among the EGFR mutation subset. And then we have some rarer alterations. We have the EGFR exon 20 insertion mutation, and then we have other atypical alterations in EGFR. And it's important to distinguish these because while all are activating oncogenesis in an overall similar pathway, the structural differences in these alterations at the protein level impact which therapies are going to be effective for these patients. And that's why it's very important to know not just is there an activating EGFR mutation, but what is that specific alteration so I know how best to treat my patients. So with that backstory, if we hone in on the classical EGFR alterations, the exon 19 deletion, the 21 L858R, again, there's been a lot of evolution in the treatment of these patients in both the frontline and the subsequent line setting. Just in the last year alone, we now have 2 combination strategies that are approved in the front line that appear to improve overall survival compared to osimertinib monotherapy alone. And as a recap, osimertinib is a third-generation EGFR TKI, originally developed to overcome resistance to previous generations of EGFR TKIs and also with enhanced CNS penetration and enhanced tolerability. This had been our standard of care for many years. And then more recently, we saw that the combination of both osimertinib plus chemotherapy as well as the combination of amivantamab plus lazertinib, improved both progression-free and overall survival compared to osimertinib alone, which has really led to an evolution in how we are treating these patients up front. And at least in my practice, I know that I'm considering combination strategies for a large majority of my patients. But to hone in on how we updated the guideline more recently, The MARIPOSA trial, this was the trial that ultimately led to the approval of amivantamab plus lazertinib, amivantamab being the bispecific EGFR MET antibody, and lazertinib, the third-generation EGFR targeted therapy that was paired with amivantamab. This trial enrolled to one of three treatment arms: amivantamab plus lazertinib, osimertinib monotherapy, so our standard at the time, and still an approved standard option, the third-generation EGFR TKI, or lazertinib alone, and patients were randomized in a 2-to-2-to-1 fashion. Now, it's important to point out that lazertinib itself is not a fourth-generation EGFR TKI. And what I mean by that is it's not expected to overcome resistance to osimertinib or in any way be better than osimertinib. It's of a similar generation to that drug. But importantly, there was an arm enrolled to that monotherapy to see, is there equipoise with that and osimertinib? And recently, there was an exploratory analysis published with that comparison, comparing osimertinib to lazertinib. So in that comparison, 216 patients were enrolled to the lazertinib arm and 429 patients to the osimertinib arm. Response rates were 83% and 85% respectively. The median progression-free survival in patients treated with lazertinib was 18.5 months with a 95% confidence interval of 14.8 months to 20.1 months. And the median progression-free survival in the osimertinib arm was 16.6 months with a 95% confidence interval of 14.8 months to 18.5 months, and median overall survival was not reached in either arm. So when you look at that clinical data, to me, it tells me that, again, while this was not a pre-specified, statistically driven analysis, that there is a relative clinical equipoise here between these therapies. Side effect profile was also similar. Numerically, among all grade adverse events, there was numerically higher rate of diarrhea with osimertinib, 44% versus 32%, and higher rate of all grade rash with lazertinib, 45% versus 31%. So basically, on review of this data, the committee felt that there was at the very least a qualifying statement that was warranted to be added to the recommendations, which is if access to osimertinib monotherapy is not possible for whatever reason, be that insurance coverage or availability, that lazertinib monotherapy may be offered as an alternative treatment recommendation. And again, this recommendation was made based off of this exploratory analysis that showed relative clinical and toxicity equipoise between the two monotherapy drugs.
Excellent. I appreciate you reviewing the evidence from that exploratory analysis and describing how it impacted not necessarily a recommendation, but a qualifying statement to the recommendation. So then you've just reviewed the evidence around changes for non-small cell lung cancer with classical EGFR mutations, as you described earlier. But for non-small cell lung cancer with rarer alterations, what updated evidence did the panel review for stage 4 non-small cell lung cancer and other activating EGFR mutations, and how did this impact the recommendations?
Yeah, so to continue on our EGFR story here, we just talked a bit about the classical EGFR alterations, and then there are other atypical EGFR alterations that, as I stated, they activate the EGFR pathway, but the treatments, we have to kind of view it with a different lens. One of those is EGFR exon 20 insertion mutation, so that leads to a kind of a different conformation of the protein, as I alluded to. This is one for which we have amivantamab plus chemotherapy approved as a frontline option. We also have the EGFR TKI sunvozertinib approved, though its access in the United States is currently an ongoing problem that we're hoping to see rectified in the future. But there is another class of EGFR alterations that are just kind of a pooled group of rarer EGFR alterations that span various aspects of the kinase domain that, again, we have kind of mixed levels of data for. In many cases, these are alterations that impact regions of the EGFR protein that render them less sensitive to osimertinib. And so when I get an EGFR mutation and I get one of these rarer alterations, at first you see the EGFR alterations, you say, oh, okay, good, we have a treatment option here. But then you always need to rethink that a little bit when you see one of these rarer alterations to try to identify, all right, what is this? Is this more analogous to one of our classical alterations, or is it a rarer alteration where I really need to think differently about the upfront management of these patients? And again, unfortunately, we don't have that same level of evidence by and large for these rarer alterations, but it does appear that in many cases, osimertinib does not have the same overall robust level of efficacy as it does for the classical EGFR alterations, and the same would go for our currently approved frontline strategies. So what we reviewed here was a single arm cohort from the CHRYSALIS-2 trial. So the CHRYSALIS-2 trial was a multi-cohort study that evaluated the combination of amivantamab, the EGFR MET bispecific antibody, with lazertinib, the third-generation EGFR TKI, in various EGFR mutation subsets. So again, this is the combination that is approved as a frontline treatment for classical EGFR alterations, but it was studied in many other settings, which is a good thing because it gives us, more data on where this treatment could be sequenced or utilized in other populations. So cohort C of this study specifically evaluated this combination in these rare atypical EGFR alterations. And what were most frequently found were the atypical alterations G719X, L861Q, and S768I. There were other atypical EGFR alterations, but those were the most common ones included. And overall, 105 patients were enrolled to this cohort, and there was a mix of patients that had received no prior therapy for their advanced non-small cell lung cancer and those who received prior therapy. In the overall population, the response rate seen was 52%, with a median duration of response of 14.1 months and a median progression-free survival of 11.1 months. When you look at that treatment-naive cohort, 49 patients, the data is numerically more robust, response rate 57%, median duration of response of 20.7 months with a 95% confidence interval of 9.9 months to not evaluated, and a median progression-free survival of 19.5 months with a 95% confidence interval of 11.2 months to not evaluated. In the previously treated 56 patient cohort, that response rate was 48%, the median duration of response of 11 months with a 95% confidence interval of 4.5 to not evaluated, and a median progression-free survival of 7.8 months with a 95% confidence interval of 5.4 to 11.1 months. So as you see in that data, activity in all settings, but the more robust activity, particularly in the treatment-naive frontline setting, which is pretty common for what we see with these alterations. The targeted therapies given up front will typically have the greatest durability of efficacy in a kind of a less molecularly heterogeneous tumor. And now a toxicity profile that's mirrored what we know about this drug, high rates of rash, paronychia, infusion reactions, hypoalbuminemia, also saw venous thromboembolism. So the same approaches that we take to this combination as in our typical EGFR with anticoagulation prophylaxis, with aggressive skin care and prophylaxis for rash up front, as well as prophylaxis for infusion reactions if using an IV formulation of amivantamab are all important. So based off of this clinical and safety data, after review, the panel did feel that this warranted inclusion as a treatment options for patients with atypical EGFR mutations, joining afatinib and osimertinib monotherapy as treatment options here. Now, it's hard to compare the data for these treatments. I will say that numerically, the progression-free survival in a treatment-naive setting was the most robust for atypical EGFR mutations treated with amivantamab plus lazertinib. The data for afatinib from the Achilles trial and some pooled data from earlier studies of like the second-generation EGFR inhibitor afatinib show a PFS of about 10.6 months, and data across studies for osimertinib suggests perhaps a PFS closer to 9.4 months, median progression-free survival. But again, I caution on looking into those details too much, again, knowing that these were not directly compared to each other. And there might be scenarios where one wouldn't want to go with a combination up front, either due to the age of a patient, their comorbidities. There might be someone where you might elect to try osimertinib first or afatinib first. But again, given these new data and the robust activity in a limited patient subset, a 49 patient subset treated with amivantamab plus lazertinib, we did feel that this warranted inclusion in our Living Guideline update.
Definitely. And I thank you for reviewing both the evidence that supported this and the recommendation that has been updated here. So as you just talked about, a lot of the recommendations here, there's new options, but they aren't necessarily directly compared to each other. So what should clinicians know as they implement these updated recommendations, and how do these changes impact patients?
My biggest take-home point, and it's something I mentioned at the outset in our EGFR-centric discussion here, is really that not all EGFR mutations are created equally. While they molecularly might lead to the activation and oncogenesis, all in a somewhat similar biological fashion, the fact that these alterations are distinct at the genetic and then subsequently the protein level in terms of how they appear structurally, that really leads to differences in treatment efficacy and in how we approach these patients. So it's not enough to just say, oh, there's an EGFR mutation, I'm going to do this. You really need to know what that specific EGFR mutation is And is it just one EGFR mutation? Is it a compound EGFR mutation? And I think if one is struggling about what that unique EGFR alteration means, it's always a good thing to do is to check in with, if you do your molecular testing with a paired commercial partner, talk to the medical science representatives from that company, ask them more about those alterations. If you run an internal panel, talk to your pathologist, your molecular pathologist, more about what that unique EGFR alteration means. Always important to clarify that if you're not sure. To bring it to the clinical level, I would say that it's true. And really, a lot of our treatment levels in the front line and in the subsequent line, but in both the classical EGFR alteration update that we saw here recently, as well as the atypical EGFR, these options that we list are not directly compared to each other. So that's where it's really important to have that patient-centered discussion, evaluating the patient sitting in front of you. Are there specific comorbidities that are going to point you in one direction? Are there specific aspects of the disease, whether that's brain metastases or a more aggressive disease biology? Those should definitely be informative. For example, someone with an atypical EGFR mutation that has a high burden of brain metastases, I probably would not initially reach for afatinib, a drug that does not have a good deal of CNS penetration. And I would probably, look at this amivantamab-lazertinib combination or possibly osimertinib. So I think those are just a list of several factors that are important when looking to integrate these new updates into clinical practice.
Absolutely. And tailoring the treatment to the individual patient and their characteristics and goals is absolutely critical here. So then we've had a EGFR-focused discussion today. So finally, what evidence is on the horizon for future updates, whether that be in EGFR or for other driver alterations for this living guideline on non-small cell lung cancer?
It seems that in the driver mutation space in particular, there's always some latest and greatest, some new update that is helpful for patients, but also is something that we then need to incorporate and think about in the sequencing of our practice. I will say more recently, we saw the FDA approval of frontline zongertinib, the novel HER2 tyrosine kinase inhibitor, which is so an accelerated approval for use of that in the frontline space for patients with HER2 mutations, the first tyrosine kinase inhibitor approved as a frontline agent. We have not yet seen published data for this frontline cohort. This has been presented at a major meeting at the ESMO meeting this past fall. The panel is anxiously awaiting this published data so that we can review it and comment on how this data should inform practice in the frontline setting. So I'd say probably that's the biggest upcoming update. And of course, there are several other studies in other subsets, exon 20 insertion mutation, where we're reviewing on other therapies and among other mutation subsets as well.
Well, we'll look forward to that evidence and future evidence being incorporated into this guideline. So I want to thank you so much for your work to continuously and rapidly update this living guideline. And thank you for your time today, Dr. Royce.
Thank you so much.
And finally, thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.asco.org/thoracic-cancer-guidelines. A companion podcast episode on stage 4 non-small cell lung cancer without driver alterations is also available. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.